name is Bob, and thank you for being here. Let me just get a quick feel for the room. How many of you are working in underserved settings? Everybody. All right. And how many of you are like medical assistants, PAs? Okay. Nurses? Okay. OT? PT? No? Nurse prac? Okay. Here. Physicians? Students of some type. And students, undergrad. Okay. And everybody else, professional school? Med school? Okay. So, all right. Good. Wonderful. So we're going to have fun together. I am not a physician, not a healthcare professional. I said, what are you doing here? I don't know. Steve Knoblich called and said, hey, you want a free trip? But I have been working with healthcare students and healthcare professionals for about 30 years. And people ask me, how did I end up doing this? And I just say, God. My wife and I connected with a gastroenterologist guy, late Young Chin, that started an organization called the Medical Strategic Network. Young was Chinese, born in the Philippines, did undergrad med school in the Philippines. While they were in med school, a bunch of med students, a bunch of Christ followers started thinking about, when are we ever going to get to live out our faith? Because we're going to be working all the time. Sort of showed up and said, well, maybe where I want you working and living out your faith is where you work and where you spend some of the best hours of your day. And they put together some thinking and some training, a bunch of med students, and they had like 400 professionals show up, including the Minister of Health for the Philippines. And these med students training these attendings how to integrate their faith into their patient care. So that's a little bit about our background. We're going to cover a lot of ground today. I've actually added some things to our session. Rather than just sort of give you a bird's eye overview, I did decide to dump the whole load on you. And I'm going to try to cover in about 45 minutes what we might normally take an entire day or 2 or 3 days to cover. So you guys ready? You want to hang on? So I want to start with a story. I was training some med students in Southern California how to do whole person care, how to not only care for the medical needs of their patients, but the spiritual needs of their patients as well. And we walked into a hospital room and we said, hi. That's all we said. And there was a lady, the patient was probably late 20s, female. Again, all we say is hi. And she looks at us and she says, I am in the hospital because God is punishing me because I had an abortion 8 years ago. Now, a lot of clinicians would have just brushed that aside. And they said that has nothing to do with why you're here. But to do so could be potentially bad news. I'm going to talk about a study in a minute. Now, this study was done with elderly patients. And they found that those patients, if while they were hospitalized, they began to think that maybe God had forgotten them because they weren't getting well. Maybe God was punishing them with this illness, or they didn't have enough faith, or they weren't dedicated enough in their faith. Dealt with an issue like that, they saw a 16 to 28% higher mortality rate in a 2-year period following hospital discharge. Now, again, this was a younger patient, anecdotally, but I think the same principles apply. And rather than brush that aside, these medical students already were beginning to think about spiritual care, whole person care. And they began to ask her some spiritual history questions. What keeps you going? What's your source of strength? Has any of this illness been scary for you? How has this affected the way you see yourself? How has this affected the way you think or relate to God? And those questions are designed to find out, what is a patient's coping system? Are there some spiritual needs there? Does the patient recognize those needs? Does the patient want to have those needs addressed? And it became very clear that this patient had some spiritual needs that she recognized and that she wanted to have addressed, and in fact gave these permission to these students to address that. And to make a long story short, within a few minutes, they had explained to her from a Christian biblical perspective how she could know that she is forgiven, that her sins are not going to be held against her because of what Jesus has done for her on the cross. If she comes to the point in her spiritual journey that she puts her trust in Jesus' death on the cross as payment for her sins. talked to her. We had found out earlier that she was estranged from her family, found out a few other details, and we shared some additional information with her, and we left. A few days later, we came back to visit with her. She was still there. Check with the charge nurses if we go okay to go in. And the charge nurse said, well, I think she has some visitors, but let me check. And I asked the charge nurse, I said, is one of the visitors her father? He said, yeah, I think so. This was one of the people she had been estranged from. And we went in, and it was a teaching hospital. Patients have a lot of people coming in and out. And said, hi, you remember us? Yeah, you came by and talked to me the other day. You remember what we talked about? And she unpacked our entire conversation, including how she could know for sure that God had forgiven her because of what Jesus did for her. Able to visit with her for a few minutes, and at the end of that visit, she said, I have no idea what I would have done if you wouldn't have come by and talked to me. I remember one student that we trained was doing spiritual care on his rotation, asking some spiritual history questions, and the attendant said, what are you doing? And the student replied, just complying with Joint Commission guidelines. And you know, people we train, a lot of times that's their first response. Incredibly, how much we're open. So let's push on. Before we do, a little bit more about myself. My wife, Diana, and I have been married for what, 2 years? No, 36 years. And this is our family. A few months ago at Disneyland, we were celebrating our birthdays, and they took us to Disneyland. My daughter is on the far left, far right. She is a nurse, OB-GYN nurse, works at a Torrance Memorial Medical Center. So we know what nursing school is like, and studying for the NCLEX, and not fun living with a student that's studying for the NCLEX. But we did that. That's her husband next to her. He is a pastor in a little community called Manhattan Beach, California. He's holding our granddaughter and our 2 grandsons. They belong to our son and his wife on the far side. They live in San Luis Obispo, and they too work with CRU, Campus Crusade for Christ, at Cal Poly San Luis Obispo. This whole idea, spiritual care, whole person care. Well, what do people think about it? What do your colleagues think about it? One survey found that the majority, that is 75% of surveyed physicians, agreed that religion and spirituality is important to patients for coping and for giving them a positive state of mind. So your peers do sort of recognize that this is important to patients. Patient views, this was a study that came out, was published in JAMA. It'll be 3 years ago this summer. Lead PI on that, Tracy Balboni, a friend of ours who is at Harvard Med, and Dana Farber. This was a study with seriously ill patients, and shockingly, they found that spiritual care is frequently desired by patients in serious illness populations, with 50 to 96% of patients wanting spiritual care. But those same patients, they said, they found only 9 to 51% of the students actually got that. So there's this huge disconnect between what patients want and then what they actually get. General internal medicine found that patients who had discussions of religion and spiritual concerns were more likely to rate their care at the highest levels, regardless of whether or not they said they had even desired such a conversation. Patient satisfaction became started getting a lot more attention during the Affordable Care Act, when reimbursement was connected with patient satisfaction. Journal of Rehab Medicine found that, in answer to is faith even good medicine for patients, that religiousness is related to significantly less depressive symptoms, better quality of life, less cognitive impairment of pain, less perceived pain. And they said that clinicians should consider taking a spiritual history. The Balboni study in JAMA also found that spiritual interventions are associated with improved quality of life outcomes in seriously ill patients. This is a study I cited earlier about higher death rate if a patient dealt with this situation, sort of what we were dealing with the patient we saw. My friend Walt Larimore, original founder of the saline solution, family practice doc in Colorado, he said, if you knew something that increased the likelihood of dying by 20%, would you intervene? Well, I would hope, if you're my clinician, I hope you would. End of life cost. When spiritual care is done, the end of life cost goes down. I'll let you look at the numbers there with these different groups. David Levy, as a neurosurgeon, was sitting in a dental chair, had a cavity, and that dentist, any dentist in the room? Oh, you no? Okay, good. Was trying to sneak up on him with that syringe, to pop him. And David attitude towards shots is he says he feels it is much more blessed to give than to receive. And so with an attitude like that, a little apprehension, the dentist, who is a Christ follower, picked up on that and said, before we start this procedure, would it be helpful if I pray for you? And Dave said, sure. So he said a short prayer, gave him the shot, filled his cavity, sent him home. David's driving home, and he has this godlike conversation. What did you think of the dentist? Good guy. Good job on the tooth. Yeah. Well, what did you think of him praying for you? Well, I thought that was good. Oh, you thought that was good. Well, why don't you do that with your patients? Well, gee, God, everybody knows neurosurgeons don't pray with their patients. I mean, what would they think? That I'm scared? I'm not confident in my ability or my skills? No, it's out of the question. Well, that conversation continued. And there would be days that David would think about doing this, but then on his way home from work, it was like, oh gosh, forgot again. So one day he had decided that he would not come home unless he offered to pray with one of his patients. He got to work and he had his victim picked out. It was this lady he was going to be doing a procedure on, and his plan during the pre-op visit, after the nurse, after the nurse left the room, he would offer to pray. He went in for the pre-op visit. The patient was there, her adult daughter, the nurse, did all the medical stuff, waiting for the nurse to leave, and the nurse wouldn't leave. And he stalled, and the nurse wouldn't leave, stalled some more. And they're like, why are you still here? So he left the room. Nurse left. He started down the hall. He sees the anesthesiologist coming. He does an about face, so no way in front of the anesthesiologist. Anesthesiologist leaves. The nurse is in there. He swoops into the room. He says something about praying with the patient. The patient and her mom were like, okay. And he says a short prayer. And when he's done, both of these ladies have tears of appreciation streaming down their faces. He told some of us in his home, he said, I realized I created this emotional mess, and I did what I always did when I would create a mess, and I would leave so that the nurses could come in, clean it up. He does the procedure at that point in his practice. He had done some really cool things. He had actually been brought in to do a case in Europe. But he told us, he said, I got more joy out of that simple procedure than anything else I'd done in my entire practice up to that point. When he went and told the daughter about the daughter was, thank you for praying for my mom. You don't know how much that meant to me and how much it meant to her as well. And so he began to incorporate more of that. And he would pray with patients. Occasionally, he would actually share the gospel with patients. He has actually written a book. I would recommend it. Gray Matter, a neurosurgeon discovers the power of prayer, one patient at a time. Phenomenal book, not only on his own personal spiritual journey, but his journey to doing whole person care. Some of the challenges, some of the pushback that he got on that, and how he responded. I already mentioned the Joint Commission. We've gone through this. They say you should do it. They softened their position a few years ago. They don't say you don't do it. They've just limited the situations where they say it must be done. Joint Commission isn't alone in this. Puchowski has pointed out that the World Healthcare Organization, or World Health Organization, says it is, get this, the ethical obligation of all healthcare professionals and healthcare systems to address spiritual issues of patients. American College of Physicians and other associations support this position. So in terms of these ethical things that I've touched on real quick, get back in your groups, talk about. What do you think about what you've heard? What are your concerns? What questions? Ready? Go. Okay, if we could come back together. Now, on this peer-reviewed material that we've looked at, we could spend hours unpacking this. You just go to PubMed and type in spiritual history, whole person care. I mean, there are hundreds of published studies on this. Vast majority of them showing the value, the efficacy, the positivity, enhanced outcomes. Now, it's not a settled issue. There are people that don't think this has any place within healthcare, but there are other controversies within healthcare about what should be done. So there's There's validity to it. So where does this leave us? And how do you go about assessing and addressing spiritual needs of patients? Well, take a spiritual history. Here's some of the questions we use, or we suggest. You can take a picture of this if you'd like. Some of these questions we came up with. Again, go to PubMed, type in spiritual history. You'll be surprised at how many hits you get. There are a lot of different inventories, mnemonics out there that you can use. Some of these we borrowed from some of those. Some of these questions came directly from the suggestions of the Joint Commission. And again, what they are designed to do is to try to find out what is the patient's coping system. Is faith a part of that coping system? How is that coping system working for them? Are there spiritual needs there? Does the patient recognize those needs? Does the patient want to have those needs addressed? So how does this fit into healthcare? I tell people over and over that I feel like within the healthcare setting, spiritual care needs to be done in the same way that medical care is done. And what I mean by that is if I presented in your office or in your clinic or your ED, and I have a pain in my side, what are you going to do? I have a need. You're going to work me up. Physical exam, history of present illness, might do some blood work, maybe some imaging. Perhaps if you reach over and during the exam, you push sort of hard and Bob, does this hurt? And I double over in pain. Well, the labs and the imaging will confirm whether or not it's appendicitis, and it is. And then you sit down, and the next step is to report your diagnosis and then your treatment plan. And at the time, you're thinking surgery might be best, and you present that option to me, waiting for consent. And I look at you and I say, Doc, I ain't having nobody cut on me. Now, do I have a medical need? Yeah. Do I recognize that need? Apparently not. And we are in Kentucky right now. What is it? Ohio's across the river. And I don't know what they do in Kentucky. But in California, where I live, if I am a sane, competent adult, and people who know me well often debate whether I'm a sane, competent adult. But if I am in California, you can't strap me down and yank out my appendix against my will. Anybody from Kentucky? Is that what you guys do in Kentucky? I assume it is. Spiritual care is done in the same way, in my opinion, in the healthcare setting. In response to a need that the patient recognizes, that the patient wants to have addressed, and in fact gives consent to do that. Spiritual care can be simply praying with the patient. Spiritual care can be reminding them that God sees them, that is available to walk with them through this journey. He has not forgotten them. Spiritual care might involve explaining to them that they can be forgiven. A lot of guilt in the hospital. A lot of guilt. A lot of fear. A lot of abandonment. Does faith have something to say about that? I think so. I think it says a lot. Or it can involve an intervention of spiritual addressing spiritual need, feels estranged from God, wants to connect with God. We'll talk about that a little bit more. You approach your patients with sensitivity, with respect, and you don't do anything without permission. Pretty much the same way that medical care is done. Do you take a spiritual history? I would suggest asking some spiritual history questions at first visit. You don't have to ask all of these. You can just sprinkle them in. You're in the history of the present illness as they're telling you their symptoms and how long it's been going on. Maybe just a quick comment, wow, that's a lot. What keeps you going and all that? Or maybe has any of this been scary? How has this affected the way you see yourself? Dr. Harvey Elder, one of my friends who does spiritual care or did spiritual care as well as anybody, he's in his 90s now. He said, anything you ask first visit is fair game for the rest of the time. Now, that doesn't mean that if you don't ask a spiritual history question, you can't just work it in. One of my friends that did med school at Harvard, she's family medicine. She has about 5 questions that she does with every visit, every patient first visit. She says it takes her about 60 to 90 seconds to do that. So you can just sprinkle these in, 1 or 2. It can be an ongoing conversation. You can play with different questions, different specialties, different themes, different situations begin to emerge over and over. Maybe you develop 2 or 3. One of the things that I do with the family med residents that I work with before we go in, when they go in and see a patient clinically, I'll say, okay, you've looked at the chart, and I get this from the med students, and I say, what are 1 or 2 potentially high yield spiritual history questions that you can ask? And you do that already. As you look at the chart, you begin to formulate, the 50 questions that you can ask about a given situation, but you don't ask all 50 questions. You zero in on 1 or 2 or 3 that you feel like is going to elicit the information that you need. You can do the same thing with spiritual history. I'm going to switch gears and sort of fast forward to different level spiritual care. Let me talk about one of the most common spiritual intervention, praying with the patient. That's probably the most common. And the way, if you think there is a need, you think there's an openness, you think there's a concern, maybe it'd be helpful. How do you know? You ask. How do you ask? Would it be helpful, before I leave, would it be helpful if I say a short prayer for you? Would it be helpful to you? Not can I? Would it be helpful to you? Very patient-centered. They get to choose. Sort of protects you from, my nurse, they wouldn't leave until I let them pray. No, would it be helpful to you? What do you pray for? Maybe things that came up in the visit. Maybe things that they're concerned about. Ask them. Anything we can pray for. I'd suggest keeping the prayer short. Short being 15 to 45 seconds. My standard prayer, God, called on you. Vilma, before, I'm not going to call on you. Can you pray for us? Here with Vilma. A little nervous about what's going on. I pray that she would know your presence, your comfort, and your care, and that you do see her and you're going to walk with her through this. She mentioned not sure who's going to be able to take care of her kids if she goes to the hospital. And I pray she'll get well and she feel better. Pray for me. It helped me make wise decisions in her care. Pray all this in your son's name. Amen. Talked about that a few years ago in a session like this. I remember somebody sitting there saying, I could do that. Yeah, you could do that. Most common form of spiritual intervention. Let's see. Now, I'm convinced everybody's on a spiritual journey. And one of the things that spiritual history does is helps you find out where they are. No interest in things of God. Maybe they're searching. Maybe they're curious about connecting with God, reconnecting with God. Maybe they have already come to faith. Maybe they put their trust in Christ, growing on to maturity. What I want to talk about real quick is what do you do when you intersect the life of a patient who's in this searching receptive mode? Now, again, you might say, well, why would we even do a spiritual history? Why would we pray? I refer you back to the first 15 minutes of our conversation. Peer-reviewed literature. We're not talking about bringing something in that has no clinical relevance. In fact, I entitled this talk, Taking a Spiritual History, Good Medicine for Patients and Professionals. I hope that we've done a little bit that maybe gives you pause. Well, maybe it would be helpful to the patient. So what do you do when you intersect this person? How do you know they're there? If they're searching, how do you know they're receptive? And I'm going to skip something, but we have some questions we call diagnostic and transition questions. And if you think they're in this searching receptive mode, maybe, I'm going backwards. One of the things that I will say at that point, I've seen other clinicians do, Mr. Smith, many people say they want to know God better. Would you say that is true of you? Now, understand, I am not asking this question to try to manipulate or steer the conversation where I want it to go. This is a truly diagnostic question. For the most part, there are 2 answers to this question. Yes and no. And if they say no, I'm going to respect that. I'm not going to continue to drive. I'm not going to try. Somebody said, well, I might get accused of pushing or, being heavy. No, I don't want to go there. They say no, I respect that. If they say yes, say something like this. When patients tell me they'd like to know God better, I'm able to take a few more minutes to explain from a Christian perspective how one can connect with God in a more meaningful way. It takes about 5 minutes. What am I trying to do here? What do you notice about this statement? I'm sorry? Yeah, not yet. I'm trying to set them up. Who said that? Very good. Usually people don't bring that up. I'm trying to set them up to give informed consent. I'm telling them the perspective I'm coming from. I'm telling them how long it's going to take. And then, would it be helpful to you to talk about this or read through this information? All right. You see how that works? A lot of times, medically, you sort of do a similar thing. This is my diagnosis. This is suggested treatment plan. What do you think? Would it be helpful to you to do this procedure or go see this other physician or whatever? And if they say no, I respect that. If they say yes before I continue, I will tell them, if you get tired, uncomfortable, you want to stop the visit or move on, you tell me, we'll move on. Medically, you do the same thing, don't you? If I'm claustrophobic and I need to have an MRI, and before you run me into that tube, or maybe while I'm in there, you'll say, hey, we need to take a break. You let us know. During the procedure, hey, you doing okay in there? Do we need to stop? If you're stitching me up and you gave me a little local, hey, are you feeling any pain? If you are, because we can stop. I can push some more meds. Yeah, same thing here. All right. This is Nicole. I met Nicole when she showed up at our summer whole person care preceptorship. She was a nursing student, and she is going to tell you in about 5 minutes a story about a patient that she had. All right.
Hey guys, my name's Nicole, and I came to METS in 2017, and I've just been working as a nurse in a hospital in Lansing, Michigan. And I'm here to share a story about how God used a simple tool called the 3 circles to share the gospel with one of my patients and what their response was. So I have been using this tool a lot in my sphere of influence at work with coworkers, patients, neighbors, and I really like it just because it's simple and clear. So a few months ago, I got a report that one of my patients was in a car accident and paralyzed from the waist down, and that's all I really knew. And then when I was looking further into the notes, I could see that it was a suicide attempt. So when I went into the room, I could just tell that this man was really soft-hearted and pretty remorseful about the whole situation. So I was asking the Lord, like, how do you want me to enter into conversation with this man? God, would you give me wisdom, help me to be sensitive to what he needs, and also bold in sharing hope with him? And so when I went into the room, I asked him, so I know that you were in a car accident, but could you tell me a little bit more about what happened? Do you remember? And he said, yeah. And he was very open with me and told me that he basically tried to drive himself into a tree and wanted to end his life, and just shared with everything else that was going on in his life beforehand. So then I asked him, well, when you drove yourself into the tree, what did you think was going to happen after? What do you think was going to happen when you died? And he said, I don't really know. Like, I'd like to believe that there's a heaven and that I'd be good enough for it, but I don't really know. And then he asked me what I thought. And so I got to just share with him like a 15-second testimony, and we were chatting about faith. And then I asked him, could I just draw you a picture that would help explain everything that we're talking about in a really clear and simple way? And he said, yeah. And I didn't have any paper with me, but I was wearing gloves. So I drew this picture on my gloves, and I'm just going to share it with you as I was sharing it with him. And so I said, hey, everyone in this world probably could agree that we live in a really broken place. You just turn on the TV, look at social media, there's brokenness all over the place. So I'm just going to represent that here. But this is not the way that God intended it to be when he first created the world. So when he first created it, it was perfect. There was no pain and suffering. There was no brokenness. We had everything we needed. But starting with the very first humans, we chose to leave God's original design to go to brokenness. We departed. Thought we could do it on our own. And this is what the Bible calls sin. But the thing with brokenness is we don't like to stay here. So we'll try all sorts of things to get out. This might look different for all people. It might look like climbing the ladder of success and work and school, making a lot of money, being successful. Some people might turn to a relationship to try to find life in another broken person. Some people might do a lot of good things, be a good person, read their Bible, go to church. And even though those are good things, they are never enough. They never get somebody out of brokenness. And some people might experience so much pain and suffering that they might just do things to numb it out, like drugs, alcohol, and even attempts of suicide. And when I said that, he just started to weep. And so the thing with these attempts to get out is They're like a rubber band. They can only stretch so far before we're snapped right back into reality that we live in a broken world and there's nothing that we could ever do on our own strength to get ourselves out of brokenness. And so that's bad news. But God loved you so much that he didn't want you to stay here. He still wanted a relationship with you, even though you went your own way. Even though we all did. For us, what we could never do for ourselves. He made a little door out of this broken world through his son, Jesus. So Jesus came down. He left his perfect place, came down, came near to us, and then he paid the price for our sin, forgiving us, canceling our sin. And then 3 days later, he rose again, proving to the world that this guy really was God and he really did love us. And he did all of this so that we could be restored back into relationship with him and be made new. And all we would have to do is turn from our ways of trying to get out of brokenness. They rip us off, rob us of joy. They never work. And surrender and trust in Jesus that he really did come. He came, he forgave you, making him the King and Lord of your life. So everyone in this world can find themselves in one of two places, either here in relationship with God or here in brokenness. And then I asked him, where are you? And he said, I'm in brokenness. And I said, well, where do you want to be? And he said, I want to be in relationship with God. And then I asked him what was holding him back. And he said, nothing really. I feel like this is a second chance. And so then I asked him if he wanted to open the door of his heart to the Lord and be made new, be restored into relationship with God. And he said yes. And so we got to pray together and he was just in tears. And it was just really cool to see somebody pass from spiritual death to spiritual life. And he told me, I had him the next few days too. And he told me that he called his wife and he shared the gospel with her. And they were just so excited to have new life in God, even though his physical circumstances didn't change. He was made new.
Real quick. Talk to somebody next to you. What'd you think of that? Thoughts, concerns, questions? Ready? Go. And then we'll do a little Q&A. You will recall that up on the screen when you came in was the title of this talk, Taking a Spiritual History, Good Medicine for Patient and Professional. Hopefully I've shown that this might be a good idea for your patients. But what about for you guys? Southern Medical Journal over 20 years ago wrote this, and I think it's more true today than it was when they wrote it. Caring about the patient is what gives joy and fulfillment to the practice of medicine, and is why many of you, chose this profession. Its absence, especially in the pressured healthcare environment, can rapidly lead to dissatisfaction, emotional exhaustion, and burnout. Practicing whole person medicine is the best kind of care for both of those who receive it and those who give it. I have found and I have seen that practicing spiritual care with patients can be incredibly life-giving, incredibly. And thank you for the work that you're doing. And the parts of society with the least of these, with all the complexities, with all the challenges, with all the frustrations, with all the limitations. And thank you for hanging in there and representing Jesus there. And I know it's hard, and I know it's frustrating, and I know it's lonely, and I know it's exasperating, but I also know it's incredibly needed. And thank you for doing that. What questions do you have? What comments? One of my friends, again, Dr. Elder, first visit with the HIV patient, he was working at STD clinic. At the end of the visit, would it be helpful if I pray for you? No. Second visit, would it be helpful if I pray for you? No. Third visit, would it be helpful if I pray for you? No, I don't believe in any of this stuff. Dr. Elder continued to manage this guy's case several years later. Visit's over. Guy's gathering his stuff. He said, could I ask you a question? He said, when I first came to see you, you would ask me if you could pray for me. And I told you no. And then you quit asking. Did you get in trouble? Did somebody tell you not to do that? It's like, no, you didn't seem like it would be helpful and I didn't want to harass you, so I stopped asking. Well, I always thought that was nice of you to ask. Would it be helpful if I pray for you before you leave? I think it would. Patient shows up with a headache and they never have a headache again, but they show up later with a stomach ache. Is there a need? You ask questions. Yeah. So I think you can continue to maybe tactfully assess. Maybe if there's a no interest, pushback, you sort of gauge that. You do that medically. Don't talk to that guy about eating right. He just goes ballistic. But you might ask every now and then, or might have a new situation where diet is relevant that you might mention something. Yeah. Yeah. I think there are different ways to do that. I think you could say something generic. You might say, patient exhibited some type of spiritual distress, offered to address that, patient gave permission, and then you could say something generic. Some clinicians I know sort of come up with their own little codes that they could put. I don't do EMR. But I know there are different fields and different places that you can put things. I think there's even little personal notes that you can put in that'll pop up when you log on for that patient, at least in some EMRs. But sometimes they'll have, some people will maybe like PWP, prayed with patient, things like that. Well, will I get in trouble? John Shin, oncologist, did med school at Loma Linda, did spiritual care, put it in the chart. Residency at Mayo Clinic, did spiritual care, put it in the chart. EMOC fellowship at Mayo Clinic, did spiritual care, put it in the chart. Did stint at NIH, saw patients in Bethesda, spiritual care, put it in the chart. Never got in trouble. In fact, the resident that he transferred the patient to said, I was reading about you doing spiritual care, and that inspired me, and I've been praying with all my patients. He got this message from a scribe, said, like, Dr. Shin, I love transcribing your notes and reading about the spiritual care you did. And John told us, he said, I had no idea my notes were that widely read. Other question. Yes, ma'am. How do you deal? Well, I think it's, again, like medicine. Most people have a specialty or a niche, and you're qualified to deal with that, or you're qualified to deal with this from a nurse prac level or, a PT level or something like that. And you're available and you, so to speak, offer to do that. I think if you're doing spiritual assessments and you see that and there's a need, you can offer to address that and let them know that you are a Christ follower, or you're a Christian, and you would come at that from a Christian perspective, and would that be helpful to you? And you respect where they're at. If they say, well, I'm Muslim and I'm into being Muslim stuff, well, okay. And I'm not the one to deal with that. Yes, sir. Yes. Make accommodations. Yeah, sure. Right. Yeah. Yeah. Sure. Dealing with spiritual care with somebody who has a church hurt. I think probably one of the best things that you could do, at least initially, is acknowledge their hurt, acknowledge their pain. And a lot of times it's pretty easy to recognize that was wrong, or I am sorry that you were treated that way. You could even go as far as to say, I'm a Christ follower, and I don't think that represents God well. Now there can be a ton of pain and a ton of work that needs to be done, and you don't have to do all of it. But I think at an initial core level, to validate and affirm that was wrong. That's, yeah. If you can say, that was wrong. Sometimes it's pretty clear. Good question. Yes, sir. Yes. Mid-90s. Yes. Yeah. Well, I think I can't speak specifically to the ACGME, where they're at on that. I remember that's when I first sort of got involved, and it was huge in the 90s. It was on the cover of Time back when we had magazines. Time magazine and Newsweek. There's a guy named Dale Matthews that was on TV talking about this, Christ follower. And I think it did wane. And my immediate hypothesis is a lot of new things do get a lot of attention and excitement, and they do wane. I don't know really if the secular world or the secularists really knew what to do with that excitement. I don't know if they ever totally bought into it, let alone got trained or comfortable in it. So it's pretty easy to see how they would forget. And I think a lot of maybe even Christ followers maybe tried it. Honestly, I'll be honest with you. I'm cognizant of the challenges of time right now. And that's one of the things we're spending a little bit more time thinking about. Frankly, honestly, it can be hard to include it, even with the people who really want to do this. So I think those are some of the things that account. Is it still effective? Absolutely. Do patients respond incredibly positively? No question. Is it life-giving? Yes, but it can be a challenge. Well, we are over time. I will be around for a few minutes if anybody wants to talk. Do occasional conferences in different parts of the country. Love to have you join us. Students, best thing we do is a 4-week summer preceptorship. I've got information on that. We may even have one or spots still open for this coming summer. So thanks for your time. Appreciate what you do.